This is Jose Fuentes, Director of Neuropsychology, and we're here at Casa Clina. We're just going to do a quick little interview about neuropsychology and some of the collaborations with occupational therapy.
Neuropsychology is really the study of brain and behavior.
Okay.
So what we're doing is we're looking at the effects of brain injury or disease and what that does in behavior that we are observing. And whether that is a physical manifestation of behavior or an emotional manifestation of behavior. Neuropsychologists have their doctorate in clinical psychology.
Okay.
But our emphasis has to be in neuropsychology.
Right.
So our electives and our emphasis in our clinical track has to be in neuropsych. We also need to do all psychologists have to do a 1-year internship.
Okay.
Before graduation.
Right.
Ours has to be at least 50% of that needs to be in neuropsychology.
Okay.
It needs to be within a neuroscience division ideally. So an interdisciplinary model, preferably within like a hospital like this or similar kind of facility.
Okay.
Then you need to do a 2-year postdoctoral fellowship in neuropsychology, specifically.
Well, that's cool.
It is. It is. So you do your doctorate, plus you have to do a 2-year residency. A rehab hospital like this is sort of like what we're bred for.
Okay.
This is really the ideal place where neuropsychologists function. But we're also in hospitals, anywhere where there is a brain injury or a question related to a brain-behavior relationship. And we don't think of it in this regard, but there's a lot of medical training that goes into neuropsychology.
Okay.
Like, for example, when we think about sleep and those sorts of things, well, sleep is impacted a lot and regulated by serotonin.
Right.
Okay, which is one of our great neurotransmitters. Mm-hmm. Well, 80% of serotonin is found in the gut, in the digestive tract. So to understand that a patient has a digestive problem may be a factor in why they're manifesting psychiatric symptoms.
Okay.
And so for us to be able to help physicians and other therapists in that area is what we do. So we have to have an understanding of endocrinology, of gastroenterology, and those pieces as well. It's not just brain as in focusing
right,
just on
you guys
the
take more like a holistic approach.
Exactly.
Okay.
And so we look at many things that impact brain function. So you would find us in a multitude of settings. So in private practice, there's a lot of assessments that we do for learning disabilities, for example.
Okay.
And of course the med-surgical world as well, med-legal world I should say, where if someone has a car accident, do they really have a head injury, or are they faking the head injury to get a bigger settlement?
Got it.
In the world of Social Security benefits, are they claiming disability, or is it truly a disability? Okay. So we also have training in what's called effort testing. Okay. Some specialize in that area, where we actually look at that as well. So you will see neuropsychology in hospital settings, in forensic settings as well. And then you will also Okay, so then what will happen is you will see then different areas where neuropsychology will be found providing all of those different services.
Interesting.
Very integrally.
Okay.
When I did my training initially, I did it in a rehab setting. And so my supervisor at that point had me work and do co-treats with speech and OT.
Okay.
And so that's how I learned about occupational therapy.
Okay.
I didn't know anything about occupational therapy prior to that point. Okay. And what I found at that point, I was doing more pediatric. That was my emphasis in training at that point in time, because I wanted to understand the developing brain. That to me I thought was a really key piece. So in that process, I learned that OTs use sensory in such a unique way that we as neuropsychologists are not trained in. Okay. So that's where I learned about the construct of like arousal and the importance of arousal and what overstimulates, what understimulates, and how do patients respond to this particular stimuli, and the integration and modulation of sensory processing. Those things became very seminal, and I was fortunate to get that sort of training. Mm-hmm. So how we work together is huge. Right. Because I can test a child on this table here. Absolutely. And get that child to do miserably. I can give that child the exact same test on a platform that sort of swivels a little bit, or just it barely moves, and that calms their senses, and they're able to focus better, they're more optimally aroused, and now I get a true sense of what they can do. Right. So for me, having a good occupational therapist to work with is hugely important for the assessment and for the treatment. Yeah. Because now I know that it has less to do with what I would look at in terms of the thinking therapies, because the thinking therapies are hugely impacted by our sensory processing. And so if we are sensorily out of control, then of course cognitively we're not going to be focused.
Right.
And so for me, it's going to be more important rather than put that child through play therapy. I'd much rather have them go to sensory integration therapy.
Right.
Okay, and in the adult world, it works in a very similar way. I want to make sure that we're working with the processing pieces that are getting in the way of their ADLs.
Okay.
It may not be a cognitive issue.
Yeah.
It may be a sensory issue that's getting in the way of that cognitive skill, of accessing the cognitive. So Colleen actually has two specialties in OT.
Okay.
You have the ortho side of the house and the neuro side of the house.
Okay.
So we have neuro OT here present.
Okay.
As well. So when I look at cognitive rehabilitation, I'm really looking at it as an interdisciplinary model.
Okay.
I'm looking at speech, OT, PT, neuropsych as a team.
Wow.
Because the cognitive is everything. It's not just a thinking skill.
Right.
You have to actually look at it holistically. And so for me, it's integral. It's just like looking at a hand and saying which finger is more important.
Yeah.
Which one can we do without? You know, either way, you're going to have to find ways to adapt in ways that aren't ideal.
Yeah.
Prior to the camera turning on, as I was telling you, I wish that one of my masters was in occupational therapy, because I really believe that occupational therapists have a really good sense of processing at a level that we don't get.
Okay.
I don't get that level of training. So I think we have a very limited understanding, and I say we as in psychology have a generally limited understanding and appreciation for some of the other disciplines, including OT.
Okay.
To look at it like an occupational therapy, just from its title, it seems like, oh, okay, so to help with occupational skills to get them back to the workforce and whatever else. But it's so much broader than that. It's really being able to understand, you know, the differences in functioning and instrumental versus functional ADLs, and being able to really work with that. And what are the barriers that are getting in the way of that? What's getting in the way of a productive day? How do we modify a productive day on the basis of disability? What does that look like 2 weeks versus 2 months versus 2 years post-injury?
Right.
Those are the types of things that are just integral to be able to work with. And while I don't know what the world of occupational therapy has, I know that I access it frequently.
Yeah.
In those areas.
Absolutely.
Okay, and so with some of the co-treats that I've done with them, have been fantastic, like vision. And who would have thought that occupational therapy works with vision? And yet it's so hugely important. And when I have that visual neglect, that patient that has that problem, my gosh, to be able to go to a OT and say, hey, we need to start working on a visual schedule here for them that takes that into consideration and getting some therapy in place so that we can teach them how to work past that neglect, or to lessen the effects of the neglect, because if you keep neglecting that, it's going to prune. It's going to go away. So now we need to go to a functional status, right? And so that's where I access OT to, okay, how do we bring that functional status into a productive day? How do we do that so that they're not neglecting that to a point where it's lost? You know, how do we bring those pieces? Well, the assessment part, in order to reach goals, there are several things we need to take into consideration. First and foremost is, what are we testing at the time that we are testing? Okay. Many times when I test somebody at, let's say, within 30 days of injury, that's going to tell me where they're at, and I may be able to get some prognosis from that, but really, I don't know that patient's prognosis until I see how they respond to therapy. Okay. So for me, the way I explain it to patients, I explain it to them as sort of a flight of stairs. And the top of the stairs is where our goal is. Now, I don't know what that is, if that's 100% of where they were, 80% or 50%. We have no idea. Okay. The only thing I do know is what step we are currently on and what's the next step we need to take. Okay. And that's the goal of assessment. Wonderful. The goal of assessment isn't to predict where they're going to be. The goal of assessment is to evaluate where they are now and what's the next step we need to take, and what are the barriers to taking that step. So as a screening tool, we use here, one of the ones that we use is called the RBANS, which is a repeated battery. There's 4 versions of this test. So I can give this test 4 different times and kind of get measures of how they're going along the way. Okay. So as an example, I'll be looking at things like where's their immediate memory at, visual spatial constructional skills, which is also very important, their language skills, their attention, and then delayed memory. Okay. And then we get an overall measure as well in terms of where they are neuropsychologically. Okay. This overall measure is not very valuable. And the reason is because if I got highs and lows over here, it's an average of highs and lows. Okay. So I'm more interested in seeing the peaks and valleys, because that's what I'm going to tie my goals to. I don't tie a goal to an overall neuropsychological process. I want to make sure if there are specific language issues, then I need to work on those. Okay. So speech therapy is what we immediately think of, right? Language, speech. Okay. Right. Well, how does that impact when they go into the community?
How does that impact them when they're doing social skills? How does that impact them when they're needing to order something in a restaurant? So how they communicate at work. Those are things that have occupational and what I'm looking for productive day issues that I need to then put in practice. And so for that, I need to go beyond just a discipline. I need to go back to that interdisciplinary approach.
Okay.
So a short-term goal may be utilization of an iPad as an example for communication.
Okay.
The long-term goal is how do we integrate that into their daily life?
Okay.
How does that factor into their daily life across different areas of their world?
Okay.
So that then becomes an issue. And is that integration going to change based on the progress they make in therapy? Because if they rehab correctly, then they may not need the iPad.
Right.
So are we needing to fade that?
Okay.
And so the long-term goals become very complex when we're dealing with patients. So now the other areas are very similar. So if there's problems with attention and problems specifically like with memory, a lot of times we think of that, so we're going to put a bunch of memory things in front of a patient. Okay, that's important. But a precursor to that is processing speed.
Right.
If you slowly process information, you're going to be limited as to how much you're going to encode. So rather than focus on memory as my cognitive rehab component, I'm going to work on processing speed.
Okay.
And that's going to be both cognitive and physically.
Okay.
So that's where I would want OT to help me with what are some things that we can do that help speed of processing, multitasking, different things that really tax memory in a different way. But it sets up the stage for learning, because the reason we look at memory is for learning. That's the goal. That's the long-term goal. That's its application. Okay. So that's what I'll be looking for. So it's a short-term goal of what's the current barriers projected to what. And it's the projected to what that gives us our long-term goals.